Okay. Uh, so hello everyone. Can you please let me know in the chat box if my audio and video is good? Hello to everyone. Please let me know in the chat box if my audio and video is good so that I can start the session. Can you please let me know in the chat box? Okay. So I think all good. Let us start. Right. So hello everyone. Welcome to this important practical session on respiratory system. So I have already taken one case discussion of neurology in the DocTutorials app, and I assume that most of you have gone through that as well. So that is also an elaborate case discussion on how to take a history of hemiplegia. So this one will be on respiratory system case discussion. And at the outset, I just want to have two disclaimers. Number one, this session will be at the level of a Final MBBS student, and so I'll try to keep it very simple. Number two, I'm always of the opinion that clinical medicine is learned at bedside and not through just any online lectures. So especially for such practical classes, the best way is to learn at the bedside. However, I'll try my best to give you some insights to the respiratory system case discussion. So I think we are good to go, and let's get started. So let me tell you that this will be a relatively fast-paced class. So I'll not be, going through too much of doubts in the comment section just because that would lead on to too much of a lateral discussion. So what I would do is I'll be going in the order of my slides. I've already shared the slides with the students. I suppose that all of you have got it, and I've already shared into my academic WhatsApp groups as well. I suppose all of you have received this PDF or the workbook of this particular session. Now, yes, so this is my Instagram academic page, and you can follow this page for updates related to medicine. And this is my medicine WhatsApp channel where I post MCQs regularly, and you can follow that channel as well for academic discussions. Right. So let's now get started. Can I have a quick thumbs up by all of my energetic children in the chat box so that we'll start this class and we'll go at a fast pace covering most of the important points in a short span of time. Okay. So I think we are good to go, right? Right. So see, I just want to tell you a few things. Number one, when it comes to a final MBBS practical examination, you should be aware on what are the common cases that are kept for your exam. Now, usually the common cases that are kept include a pneumonia, then you can have pleural effusion, cavity, fibrosis, bronchiectasis. And when I say fibrosis, cavity, bronchiectasis, it can be due to different etiologies. You very well know that tuberculosis can result in cavity, tuberculosis can result in fibrosis, which you call as a post-tuberculous fibrosis or a post-TB fibrosis. And bronchiectasis can also develop as a sequelae of tuberculosis. And you can have one pathology having multiple etiologies. So fibrosis is not always due to a tuberculous sequelae. It can also be due to a part of interstitial lung disease, maybe disorders like sarcoidosis. Then lung abscess, mass lesion, chronic obstructive pulmonary disease, and bronchial asthma. Well, these are the common cases that are usually kept. Some of them may be long cases, some of them may be short cases. But if you remember my session on hemiplegia, again in the DocTutorials app, I've always told you when you try to dive into a system like neurology or respiratory system, you've always got to consider the various anatomical sites that can be involved. Okay. So just like neurology, in case of respiratory system as well, can you just think of the possible anatomical sites of involvement? You can have the lung parenchyma being involved. Yes. For example, alveoli. Alveoli is a part of lung parenchyma. So a disorder like pneumonia can involve the lung parenchyma. You can have disorders involving the lung interstitium, which can be a viral pneumonia, which can involve the interstitium, correct? So certain atypical pneumonias can involve the interstitium. Interstitial lung disease has predilection for involving the interstitium. Then you have got disorders involving the pleura. There can be pleuritis, which can subsequently result in pleural effusion. Disorders involving the pulmonary vasculature. Can you think of examples? Pulmonary arterial hypertension. Disorders involving the tracheobronchial tree. We could be discussing a case of endobronchial tuberculosis, right? That is, even TB can involve the larger airways as well, endobronchial tuberculosis. Then you can have the thoracic cage being involved in disorders like kyphoscoliosis, in disorders like ankylosing spondylitis. And sometimes you can have disorders which can have combinations. For example, a disorder like ankylosing spondylitis can definitely involve the thoracic cage, resulting in a reduced chest expansion, possible, because you can have the costochondral junctions being involved in ankylosing spondylitis, resulting in fusion and subsequently reduced chest expansion. At the same time, this disorder, ankylosing spondylitis, can also involve the lung apex, causing a fibrosis as well. So even in respiratory system, you can think of anatomical sites and the pathologies that affect these anatomical sites. I hope it is clear. Now, moving forwards to the symptomatology. Now, when you take a case, a long case for your exam, it is important to have a checklist of the common respiratory symptoms. And if you have that checklist in mind, you will have a direction in which you will take the history. So let me tell you what are the important symptoms to be considered. Number one, cough. Yes. Number two, hemoptysis. Number three, breathlessness. Number four, chest pain. And number five, fever. These are the five important symptoms, whereas certain patients may also have certain symptoms in certain scenarios like hoarseness of voice, stridor. For example, if you have an airway obstruction, the patient might have stridor. So these are the important symptoms that you should be aware about, right? Okay. Now, let us quickly go into more details. When you take a history in respiratory system, what are the points to focus in the history? See, let me tell you, when you want to reach a diagnosis, I know that many students are scared when they get a long case of respiratory system for their final MBBS practicals. You are concerned, oh my God, will I get the diagnosis right? Will I land up in a misdiagnosis? I'll tell you, be calm and composed and go in an order. You are more likely to come to a correct diagnosis. I'll tell you a few points to be careful about. Number one, see, duration of illness. This is quite important. Duration of illness. Now, why is the duration of illness important? I'll tell you some point. If you agree with me, you please give me a thumbs up in the chat box. So my point is this. Suppose you have got a patient presenting with fever and cough for 5 days duration. And another patient is there, another case kept for the final MBBS practical, having fever with cough of 2 months duration. Now, which of these two will fit into a clinical picture of a pneumonia, like a bacterial pneumonia? See, when you have got a short duration illness, you are likely to have a diagnosis of bacterial pneumonia, possible. And which out of this will have a possible diagnosis of tuberculosis? The second one, right? Because it is relatively long standing. I'm not saying that any case with fever and cough of 5 days is a pneumonia, but I'm just trying to tell you that there are certain differentials that you should consider when the patient presents with a short duration illness versus the differentials that you should consider in a patient with relatively chronic illness. So that is very, very important, the duration of symptoms. Okay. Now, if you consider a case of, say, a suppurative lung disease, what are the two important suppurative lung diseases that you actually know about? The bronchiectasis and lung abscess. These two are the important suppurative lung diseases. If I give you a history of a patient who has a long duration respiratory symptom, he has been having, say, a cough for the past 2 years. and the patient is also having the foul smelling productive sputum with certain episodes of exacerbations, especially during respiratory infections. So when you get such a long duration history, which suppurative lung disease are you thinking about? Bronchiectasis or lung abscess? You should be thinking about bronchiectasis. Now you will think about this only when you know the natural history of the disease. This is why I want all my children to know about the natural history of these important cases that are going to be kept for your final MBBS practicals. Like how is the evolution of symptoms in each case? Because if you know that, it is going to be relatively easier for you, right? I hope that is clear. Next, the chronology of symptoms important. Though I told you this checklist, I'm not telling you that you ask symptoms only based on this order. You have to ask symptoms based on the symptomatology that the patient had in that particular chronology, and this one is just a checklist so that you do not miss out on important symptoms. Okay, right. The description of symptoms also is very important, which I'll be highlighting to you very soon. And the relevant negative history also you have to ask. But I just highlight to you one point, the relevant negative history. I've seen sometimes students when they present cases, as a negative history, they say negative history of almost every symptom, whatever be the symptom, like neurological symptom, cardiovascular symptom, respiratory symptom. You need not bring in all negative history into one case. It is all about the relevant negative history pertaining to that case. And for that, you will have to use your common sense. Okay, right. Now, coming to the description of symptoms. So, what will happen in the next few minutes is that I'm going to discuss with you uh, some points, important points. As I said, I am not going to, go for a very detailed description of all these symptoms. But in this particular lecture, I'm here to make it more easy for you. So what I'll try to do is I'll give you the most important questions that may be asked for your practical exam and the points that you should be asking in history so as to reach a diagnosis. Now, commonly about cough, the examiner asks you the definition for cough. This is a common question. So, cough is actually a forced expiration against a closed glottis. That is the definition. And what is the mechanism of cough? This can be initiated by certain mechanical or chemical stimuli. Mechanical stimulus like maybe a mucus. Okay, it can be a mucus, which can be a mechanical stimuli, which can trigger the cough reflex. And again, when the patient has cough, you please ask the type of cough that the patient has been having. Is it an acute cough or is it a chronic cough? Now, why is this important? The reason is this is important for narrowing the differential diagnosis. In case of an upper respiratory tract infection, in case of a lower respiratory tract infection like pneumonia, or in case of foreign body, the patient is likely to have an acute cough. Whereas in case of chronic cough, you have got a wide range of etiologies. And what are the possible etiologies that you should consider? Chronic bronchitis. We know that the chronic obstructive pulmonary disease, the COPD, has different domains, one of which is the emphysema domain, the other one is the chronic bronchitis domain. And which domain is more likely to present with a chronic cough? It is the chronic bronchitis domain. Then pulmonary tuberculosis, carcinoma lung, lung abscess, bronchiectasis, bronchial asthma, interstitial lung disease. Now let me tell you, whatever points I have written in this workbook, I want all my children to have these points right at your fingertips. Because in your practical exam, the examiner is probably going to ask you similar questions. And they'll be really impressed if you can answer it in a flow. Just like they ask you, what are the causes of cough? If you tell, sir, acute cough, chronic cough, acute cough, these are the etiologies that I'll consider. Chronic cough, these are the etiologies that I'll consider. The examiner is likely to be impressed. Okay, so I hope it is clear. Now, chronic cough, what is the duration? See, some textbooks say that the duration more than 2 months is chronic cough, but in certain references, they give the timeline as 1 month. So, usually above 1 to 2 months is considered chronic cough, but most of the respiratory system textbooks go for more than 2 months for chronic cough. So, if all my children are clear with this, can you please give me a thumbs up? Can you please give me a thumbs up? Now they might ask you, see about the two type of cough. Favorite Viva question, they might ask you, tell me the causes of productive cough Tell me the causes of dry cough. Favorite question. So productive cough occurs in disorders like upper respiratory tract infection, pneumonia, chronic bronchitis, suppurative lung diseases. I've already told you what are the suppurative lung diseases, the lung abscess and bronchiectasis, the pulmonary tuberculosis as well as pulmonary edema. These are the causes of productive cough, right? Important. Now, they might also ask you what are the causes of bronchoria, copious sputum production. Okay, because when you take the history, you know when the patient says that he has a productive cough, you have to inquire about the approximate amount that the patient is coughing out. So if the patient has copious sputum production, how it helps you is that it helps you to narrow the differential diagnosis. Two important disorders that I will consider about a copious sputum production. One will be bronchiectasis, the other will be lung abscess. But there are certain other rarer entities also that I will consider, like an empyema rupturing into a bronchus, as well as a severe form of necrotizing pneumonia. Right? That is clear. Okay? Right. So I hope all of you are able to follow and the pace is good. Can you also please share this video to your friends who are facing the final MBBS practical examinations so that they also will be benefited. Okay, you can share in your batch groups as well. Now coming to dry cough, again favorite question, the examiner will ask you what are the causes of dry cough. You have to consider pleural diseases. So some disorder that is involving the pleura, maybe it could be a pleuritis that can cause a dry cough, and even the upper respiratory tract infection and pneumonia. Though I told you that it is productive cough, maybe during the early stages of upper respiratory tract infection and pneumonia, you may have a dry cough. Okay, that is because if you take pneumonia as an example, in the early stages of pneumonia, whatever fluid is there inside the alveoli, that is taken up by the macrophages. So initially you will have a dry cough. But later, when the capacity of macrophages is exceeded, that is when you will have a productive cough in case of pneumonia. Then interstitial lung diseases, again very well known for a dry cough, important. Another favorite question for your Viva is what are the causes of nocturnal cough? Because when you ask history of a cough, you have to ask the patient about any sort of diurnal variation. Now, what do you mean by nocturnal cough? Does it mean that it is only present in the night? No, it is not like that. A nocturnal cough means the predilection is more towards night. That is what is a nocturnal cough. Okay. So what are the causes of a nocturnal cough? It could be due to asthma, can cause cough towards the night. Then LV dysfunction, that is left ventricular dysfunction, even that can cause cough. And can somebody tell me, LV dysfunction producing a nocturnal cough? Can you tell me what is it commonly called? It is sometimes referred to as a cardiac asthma. Very, very important. Sometimes referred to as a cardiac asthma, right? And then even a post-nasal drip associated with some infections can also have a predilection towards night. Okay, I hope that is also clear. Now these MCQ points are clear. I mean, practical points are clear. Okay, right. Now coming to the nature of sputum. This again is important. Again, examiner favorite for the Viva questions for the practical exam on the different types of sputum. So one favorite question is the rusty sputum. So rusty sputum is associated with pneumonia because the sputum will contain hemosiderin-laden macrophages, hemosiderin-laden macrophages, hemosiderin-laden macrophages, hemosiderin-laden macrophages, and that is responsible for the rusty sputum. Some examiners might ask you, okay, tell me what is the reason for rusty color? It's because of the hemosiderin-laden macrophages. Now, I have already taught you in my lectures in the DocTutorials app about the stages of pneumonia, if you remember, about the stages of congestion, red hepatization, gray hepatization, and resolution. So during the red hepatization phase, you will have these RBCs. So subsequently, the hemoglobin getting converted to hemosiderin, macrophages taking it, that is responsible for the rusty sputum, important. Then you have got the mucoid sputum, again associated with chronic bronchitis. We know that in chronic bronchitis, the patient has long duration productive cough, which is usually mucoid. Purulent sputum can occur in any bacterial lower respiratory tract infection. Maybe it could be a lung abscess, in bronchiectasis, and even some cases of pneumonia can also have a purulent sputum. Foul smelling sputum in lung abscess, bronchiectasis, anaerobic bacterial infections that you should be. Then the pink frothy sputum. I'm sorry for this. This should have come here. Okay. Pink frothy sputum is seen in case of pulmonary edema. This is also important. And serous sputum in bronchoalveolar cell carcinoma. One thing I want to tell all my dear students is, suppose in exam, the examiner is asking you, tell me about the different kinds of sputum. Please start with common ones. Instead of saying a serous sputum in bronchoalveolar cell carcinoma, you please start with common ones like rusty sputum, mucoid sputum, like that. Okay. Now, can anybody tell me in which condition do you get something that is known as red currant jelly sputum? In which condition do you get the red currant jelly sputum? Red currant jelly sputum. Can somebody tell me? It is associated with a Klebsiella pneumonia. Okay, associated with a Klebsiella pneumonia, you may get a red currant jelly sputum. Okay, let's go to the next one quickly. Now, next symptom that you have to analyze after this cough is about hemoptysis. Hemoptysis again is a favorite Viva question by the examiner. Again, let me tell you something. In this session, I am trying to restrict myself to the core aspects of respiratory system. As I said, I am not going for a very elaborate discussion. I am only telling you points that are most important for you from a practical exam point of view. Now, hemoptysis, the examiner will ask you what is hemoptysis. Hemoptysis means coughing of blood, and remember, when you say hemoptysis, the source of blood should be below the level of vocal cord to say that it is hemoptysis. Examiner will definitely ask you on the causes of hemoptysis. This can be pulmonary tuberculosis, carcinoma lung, lung abscess, bronchiectasis, pulmonary embolism, the use of anticoagulants, and certain connective tissue disorders like systemic lupus erythematosus. Because if you have listened to my lecture on SLE, I have told you that SLE can result in something that is known as pulmonary alveolar hemorrhage. Pulmonary alveolar hemorrhage can be there. Pulmonary alveolar hemorrhage, and such patients can present with hemoptysis. And another question is commonly, what is massive hemoptysis? When there is more than 600 ml per hour, that is what is referred to as a massive hemoptysis. More than 600 ml per hour in 24 hours. That is massive hemoptysis. Certain textbooks say 400 ml, but majority of them say 600 ml. If it goes above than that, it is massive hemoptysis. Again, a favorite question of the old school examiners that I would say is the differences between the hemoptysis and hematemesis. Again, very important. They'll be expecting answer in this particular format in a order. First of all, about the preceding symptoms. Hemoptysis patient will be having cough as the preceding symptom, whereas in hematemesis, the patient will be having nausea, vomiting. The color of the blood will be bright red in case of hemoptysis, will be dark brown in case of hematemesis. The frothy nature is present in hemoptysis, absent in hematemesis. The reason is because some air bubbles are getting mixed, resulting in a frothy nature. Melena is present in hematemesis, absent in hemoptysis. The patient with hemoptysis will have the background respiratory disease, whereas patients with hematemesis may have a background history of maybe an acid peptic disease or maybe an underlying chronic liver disease. Okay, right. Let us go to the next symptom. Meanwhile, can you just let me know in the comment section if my speed is okay? I hope my speed is okay and you're able to follow. As I said, I'm trying to go relatively quick without checking much into the doubts so as to save time and so that you get a comprehensive overview in a short duration of time. Okay. And as I said, please also share this with your batchmates or maybe juniors who are preparing for the medicine practical examination. Coming to the dyspnea. Dyspnea, what is the definition of dyspnea is an important question. So dyspnea is unpleasant awareness of one's own breathing. That is the definition of dyspnea. And dyspnea and breathlessness are slightly different, almost same, but slightly different. What is dyspnea? Dyspnea is breathlessness out of proportion to the level of physical exertion. I can say dyspnea is out of proportion. What does that mean? See, suppose I am running for 50 meters. If I am running for 50 meters, I may also have breathlessness, and maybe another patient who has some sort of a respiratory disease or cardiac disease may also develop breathlessness. But if, after running 50 meters, somebody is too breathless, that is when you say this is out of proportion to the level of physical exertion. That is what is called as a dyspnea. Then definitely the examiner will ask you about the causes of dyspnea. Because when you take the history, you have to say, see, let me tell you one thing. When you take the history of a patient with breathlessness, you have to communicate to the examiner how severe is the breathlessness and how is that possible. You have to tell how much the breathlessness is limiting his daily activities. And I'll tell you a couple of points in the next slide related to this. Okay. Now, one definite question for your practicals will be on the causes of dyspnea. And you can say in an order rather than giving a clumsy list of the causes of dyspnea. Why don't you give the examiner that or a list like this? There are different types of breathlessness: cardiac, which can be due to heart failure. Even left heart failure can have breathlessness. Right heart failure can have breathlessness. Respiratory, asthma, COPD, interstitial lung disease, pneumothorax, acute respiratory distress syndrome, pulmonary embolism. Metabolic conditions like diabetic ketoacidosis, lactic acidosis, uremia, salicylate poisoning, ethylene glycol poisoning. Then others, it could be skeletal problems like kyphoscoliosis, ankylosing spondylitis, neuromuscular problems like myasthenia gravis, amyotrophic lateral sclerosis, high cardiac output states like anemia, thyrotoxicosis, beriberi, and it could be even psychogenic as well. This list should be in your fingertips. Very, very important. As I said, whatever I am teaching you today, all the points, it has to be in your fingertips. Very, very important. Now, something which I've already taught you in my cardiology lectures is about two grading systems. One is the NYHA functional classification and other is the Modified Medical Research Council scale. Now, why am I discussing this in the context of breathlessness? It is because it will help in grading the breathlessness. Now, first of all, you tell me the NYHA functional classification is applicable to patients having what sort of disease? Cardiac disease or respiratory disease or any of them. Remember, NYHA functional classification is applied for patients who are having some sort of underlying cardiac disease, and based on the severity of breathlessness, there are four classes: class 1, 2, 3, 4. Class 1, wherein there is no significant limitation of physical activity and patient has no symptoms with ordinary exertion. Class 2, slight limitation of physical activity, whereas ordinary activity can cause symptoms. Class 3, marked limitation of physical activity, less than ordinary activity causes symptoms, and asymptomatic at rest. Okay, no symptoms at rest. Class 4, inability to carry out any physical activity without discomfort and symptoms at rest. This is about NYHA functional classification. But what is the problem with this NYHA functional classification? See, suppose in your practical exam, if you have got a long case of cardiovascular system, you can say the difficulty that the patient experiences based on NYHA class. That is possible. But what is the disadvantage? See, it is because it is relatively subjective. Because you can see they are using terms like ordinary activity, less than ordinary activity. Now, something that is an ordinary activity for you may not be an ordinary activity for me. Okay, so you can have variations. If you ask me, come on, sir, let us walk for 3 kilometers, I would say, I cannot walk for 3 kilometers. I'm, feeling so tired. But you might say, no, I'm walking daily 3 kilometers. I'll tell you, you have this habit of walking daily 3 kilometers. I don't have this habit. So that is what is ordinary for me may not be ordinary for you. That is what you've got to understand. Okay, right. Now coming to the MMRC. Now MMRC is again another grading of dyspnea. This can be applied to patients not only for having respiratory disease, even for patients having cardiac disease as well. So do not think that this is only for respiratory. Unlike NYHA, which is applied only for cardiac, MMRC is for respiratory and cardiac. I'm not going into too much details regarding MMRC, but for the time being, I can tell you one thing, that MMRC is a more descriptive type of grading and more objective, because they have a more elaborate discussion on the description of the patient's symptoms, and we are likely to be more accurate when we use this MMRC in comparison to the NYHA. Again, this is graded based on the 0, 1, 2, 3 and 4. Okay, right. Next, again, the examiner might ask you about the causes of acute breathlessness. Again, very important. This is a favorite question. The causes of acute breathlessness include an acute LV dysfunction, pneumothorax, pulmonary embolism, acute exacerbation of bronchial asthma, acute exacerbation of COPD, foreign body inhalation, cardiac tamponade, and a laryngeal edema resulting even in anaphylaxis and a subsequent breathlessness. This is again a common question that is asked in your Viva. Okay. Now coming to the mechanism of dyspnea, again that is going to be a question that is asked. Now when it comes to mechanism of dyspnea, again a favorite question. See, you've got certain afferent signals which will carry these sensations. So the afferent signals are carried by certain central chemoreceptors which are located in the medulla, certain peripheral chemoreceptors which are located in the carotid body and aortic arch. You also can have certain mechanoreceptors that are located in the upper airways, lungs, and the chest wall. Now, the central as well as the peripheral chemoreceptors, they are often activated when the patient has some sort of hypoxia, hypercapnia, and acidosis. So these are the triggers for the central as well as the peripheral chemoreceptors. Whereas the mechanical chemoreceptors in the upper airways, lungs, and chest wall, they are actually triggered when you have got a condition like, say, a bronchospasm, foreign body, and even a pulmonary congestion. And pulmonary congestion can result in stimulation of what receptors? Can somebody tell me? Okay, can somebody tell me? Pulmonary congestion, can somebody tell me? J receptors. So J receptors are getting activated. Okay, right. So these points are important. Now next is, when you take a symptom analysis of the respiratory system or a respiratory system case, often you get confused. Sir, how to reach conclusions whether the breathlessness is due to cardiac cause or respiratory cause? This often happens because the patient is not going to tell you, look, I am a long case of respiratory system, or look, I am a long case of cardiovascular system. The patient is just going to tell you that he has got some breathlessness, and it is you who will have to come to conclusions whether it is cardiac or respiratory. Now, the examiner will ask you, how can you differentiate between cardiac and respiratory causes of breathlessness? One point that you can say is that you will look at the associated symptoms. If the patient is having associated symptoms like chest pain, palpitations, or syncope, you are probably looking at a cardiac cause of breathlessness. Then symptoms like orthopnea and PND. Now, what is orthopnea? What is PND? Orthopnea is a dyspnea that occurs immediately when the patient assumes a recumbent position and is relieved on sitting up. That is called orthopnea. Whereas in case of paroxysmal nocturnal dyspnea, yes, here also the dyspnea is in the recumbent position, but that is not immediate like orthopnea. It usually happens after 2 to 3 hours of sleep, and often the patient wakes up from sleep with air hunger. This is what happens in PND. Now, orthopnea and PND, I can tell you, is that it more favors cardiac cause. But I cannot make a definite statement that orthopnea and PND is only seen in cardiac cause. No, but it is more suggestive of cardiac cause. For example, when the patient is having orthopnea, you can have left heart failure as a cause, even chronic obstructive pulmonary disease, that is what? COPD, even bilateral diaphragmatic palsy, and even a patient with gross ascites can have features like orthopnea. Now, can somebody tell me what is going to appear first? Is it going to be orthopnea or is it going to be PND? What is an early symptom? Can you answer in the comment section? I'll just wait for your answers in the chat box. Which appears first? Is it going to be orthopnea or is it going to be PND? And which is suggestive of advanced also, you tell me. So first, what appears first? Now, another question the examiner might ask you is on the mechanism of PND. Now, one common mechanism is both orthopnea and PND occurs in the recumbent position, and automatically all of you know that in the recumbent position there is more venous return. So increase in venous return is definitely one reason why the patient develops orthopnea and PND in the recumbent position. And especially if the heart is compromised. Orthopnea occurs when there is a severely compromised heart which is not able to accept the increase in the venous return. So I can see paroxysmal nocturnal dyspnea is the answer to the question that I just asked a while back. It appears first, whereas orthopnea occurs in more advanced cases and indicates more severe cause of or severe case of left heart failure. Okay, right. Now the mechanism of PND, in addition to the one that I just told you, there are certain additional mechanisms. Because you see, in case of PND, it appears after a while, right? So why there is a gap of 2 to 3 hours? Because when you sleep, when you are in the recumbent position, the fluid in the interstitial compartment can come back to the intravascular compartment. So it will take some time for the interstitial fluid to come back to the intravascular compartment, which is why, there is a 2 to 3 hour time delay. Another point is that in sleep there is a depression in the respiratory center, or the respiratory drive will be depressed. That again can contribute to the mechanism of PND. And another mechanism is an increased sympathetic activity in the REM sleep, also contributing to the mechanism of paroxysmal nocturnal dyspnea. Right? Clear. Now coming to a few more other points which again can be asked, because see, when you take the history, you have to ask in what position the patient is having some sort of worsening of breathlessness. All these are important points that you should be asking in the history. Now, what is trypopnea? Trypopnea means the patient having dyspnea on lying to one side. In either side, the patient is having dyspnea, that is called trypopnea. Platypnea is a dyspnea on standing. Okay, and that occurs in patients who are having a intracardiac shunt, like an atrial septal defect, maybe an intrapulmonary shunt in case of some sort of a pulmonary AV malformation. And a relatively newer term is this bendopnea, wherein dyspnea appears on bending. So the patient is bending, for example, as if to tie a shoelace, and then he develops breathlessness. This is referred to as a bendopnea, which is dyspnea on bending. That is also very important. Okay, right. Again, dyspnea on bending, it also happens in case of heart failure. Right? Okay. Now, chest pain. Now, chest pain, is it a symptom that is specific to respiratory system? No. So chest pain has different causes: cardiac chest pain as well as non-cardiac chest pain. But remember, even certain respiratory diseases can present with chest pain, and let us see what are those diseases. When you think about cardiac cause of chest pain, you can have angina, pericarditis, and even patients with mitral valve prolapse can also have vague chest pain. The non-cardiac causes, the common ones, are related to the gastrointestinal system, that is a peptic ulcer, gastroesophageal reflux, herpes zoster, costochondritis, disorders like esophageal spasm and rupture. Now coming to a few respiratory system conditions like pleuritis, mediastinitis. So certain inflammatory pathologies of the respiratory system, even pneumothorax and pulmonary embolism. So you should know what are the respiratory diseases that can present with chest pain. This can be one of the questions that may be asked in your Viva. Then aortic dissection can also present with chest pain. Okay, it's a favorite question for examiners. Now another point is regarding fever. Now fever is again a common symptom, especially when you have pneumonia, tuberculosis as the case, maybe lung abscess. Patient can present with fever. And what is the normal body temperature? 36.8 plus or minus 0.4 degrees Celsius. This is a value that is given in Harrison. Certain textbooks can have slight variations, but I'm just quoting what is given in Harrison. Or I can say 98.2 plus or minus 0.7 degree Fahrenheit. Okay. Now let me ask you something. I'm just asking you this question in your chat box. I'm just waiting for your replies as well. Tell me, when do you call it high grade fever? Above what temperature level is there, something like that? When do you call it high grade, when do you call it low grade? Because when you take a history, the examiner will be asking you, okay, is it a high grade fever or low grade fever? Obviously that question will come. Now tell me, what is this high grade, what is low grade, what is the temperature distinction between a high grade fever, low grade fever? Let me tell you, there is no such temperature description. It is only a subjective description. You will ask the patient, was the fever very high? Okay, was it high temperature? What did you feel like? Was it feeling like you had very high temperature? So it is a subjective feeling, it's a high grade fever, and the patient sometimes might say that it is a low grade fever. Now what are the causes of fever? In case of respiratory system, it could be due to certain upper respiratory tract diseases, lower respiratory tract infections, pulmonary tuberculosis, as well as suppurative lung diseases are some of the etiologies that can present with fever. But even other etiologies like maybe a bronchogenic carcinoma can present with fever. Okay, but let me ask you, in general I am asking you, what is that respiratory disease that presents with a high grade fever with chills and rigor? Can you tell me high grade fever with chills and rigor? It could be pneumonia, it could be lung abscess. So pneumonia and lung abscess can present with fever which is very high grade and with chills and rigor. That is possible. Okay, so that is clear. Now, when it comes to the examination, so basically I've just given you an outline on the checklist of the important respiratory symptoms and the description that you should be searching for in the history and the possible important, the most important Viva questions that you should be aware about. Now, when it comes to examination, after you just go for the vitals, you will have to go for the head to foot examination as well. It is important to look at the vitals, and after that, when you go to the head to foot examination, you will have to look at important parameters, maybe any feature suggestive of a pancreas tumor, any feature suggestive of a superior vena cava obstruction like a puffy face, any feature suggestive of a bronchogenic carcinoma, any feature which I just told you. And but something most important is any respiratory condition, you will have to look for features of respiratory failure. This is exactly what I wanted to tell you. Respiratory failure features you should be aware about. This is again very important. So you should be looking out for features of respiratory failure. That is number one. Whatever be the case that you have got, whether it is pneumonia, whether it is lung abscess, bronchiectasis, tuberculosis, COPD, asthma, whatever it is, you have to note down in case sheet about any feature of respiratory failure is there, and for you to know that, this list should be there in your mind. What are the important features? The most important, cyanosis, very important. Then bounding pulse. Bounding pulse is a feature of respiratory failure. But does that mean that the only condition with bounding pulse is respiratory failure? No. Okay, so altered sensorium, palmar erythema, warm extremities, flapping tremor, conjunctival chemosis, papilledema, and some sort of muscle twitching. These are the features of respiratory failure. So for you, in your practical exam, this list should be there. Okay, so if you don't know about the features of respiratory failure, there is a chance of an exam failure. So I want you to know this list by heart, very, very important. And sometimes, it can help you make, conclusions as well. For example, let me just give you a clinical scenario of a patient who is having a chronic obstructive pulmonary disease, who is brought to the emergency department with an acute onset breathlessness. Now, this could be an acute exacerbation of COPD possible. But don't you think that such a smoker is also likely to develop maybe a coronary event like an acute coronary syndrome, and subsequently there is a pulmonary edema? So patient brought with breathlessness, and you are seeing that the patient is definitely having some sort of an air hunger. Can you tell me some finding? You just touch the patient and tell that, okay, this is due to respiratory failure and not due to cardiac failure. What is that most important finding? So you can definitely say that the warm extremities, because in respiratory failure you will get warm extremities, whereas in case of the cardiac failure you are likely to have cold extremities. This is one very, very important one. Okay, so these are the features of respiratory failure. Okay, now coming to the proper examination of the respiratory system, it is also important to examine the upper respiratory tract. So you should not be missing out on the examination of the upper respiratory tract. But again, in this discussion, I'll be quickly focusing on the important points, especially in relation to the lower respiratory tract. So as always, there is inspection, palpation, percussion, and auscultation. So let me tell you, well, this is an online class, so I may not be able to demonstrate these findings out here, but I can help you, help you just to give you a list on the important points that you should be looking out, and also the important Viva questions. Okay, as I always say, if you're listening to this class, once you're done with this class, I would always suggest you go to the wards, you examine the respiratory system in a patient. That is the best way of learning. And suppose you are not in the wards right now, you are at hostel or home, maybe your friends or parents, you just examine once properly. How much ever you read about the examination, if you do not practice in a normal individual, at least, you're not going to do it in the exam. So please, once at least, do a proper system examination in a normal individual. Okay, so when it comes to inspection, please look out for certain points. Now this is very important. Often students, when they learn for their practical exam, they do not make a checklist of the findings that they should be looking out for inspection, because what happens is that they might forget the points what to be looked in the inspection part. Now in your exam, let me tell you, to pass a final MBBS exam, what is most important is that, number one, a basic history taking and coming to conclusions. That is again very, very important. Basic history taking and coming to conclusions. Second is about the system examination. You have to know how to examine in a proper format. You should not be too haphazard in your examination, because if the examiner is asking you, okay, tell me what are the inspection findings in the respiratory system in this patient, then you will have to have in mind, okay, these are the findings that you should be looking at, and then you will have to say the inspection findings as well. Okay, because definitely for final MBBS practical examination, not only will you have the symptom analysis part, you will be taken to the bedside, you will be asked to demonstrate some or the other finding. Okay, right. So what are the points in inspection of chest that you should be looking at? Number one, shape of chest, position of trachea, position of apex beat, respiratory movements, respiratory rate, rhythm of respiration, type of respiration, intercostal retraction, and whether there are any dilated veins, visible pulsations, scar, sinuses, or edema of the chest wall. These are the important points that you should be looking at. Now, I'll be just quickly taking you, without wasting any time, quickly I'll be taking you through the important points which can be asked by the examiner regarding each of this. Okay, right. Now, let me tell you, shape of chest. So shape of chest, what is the examiner going to ask you? What about, comment on the shape of chest. Now you might tell, sir, it is a normal chest or a normal shape of chest. Now the examiner will ask you, tell me what is a normal shape of chest. Now you have to say a normal shape of chest is bilaterally symmetrical and elliptical. I repeat, normal shape of chest is bilaterally symmetrical and elliptical, and in a normal chest, the ratio between the transverse diameter and the AP diameter comes to around 7:5. That is what you should be doing at. Okay. Now, what are the abnormalities in shape? Again, important. The examiner might ask you, tell me a few examples of abnormalities in the shape of the chest. Flail chest, when this same diameter that I was talking about becomes 2:1, it could be a flail chest. Barrel shaped chest, 1:1. Pectus excavatum, or a funnel shaped chest, where you get a funnel shaped depression over the anterior part of the chest. Pectus carinatum, or pigeon chest, where you get a forward protrusion of the sternum. Then a rachitic chest, where you get bead-like projections in chest, as in case of rickets. And also you may have the thoracic kyphoscoliosis. I'll just show you some of the important pictures here, and you can very well see this is a barrel shaped chest. I hope you are able to appreciate. Then this is a patient with a kyphoscoliosis. You can appreciate the scoliosis part. This is the pectus carinatum. This one is pectus excavatum, and these are the small beaded projections that you can see in case of rickets. The rachitic rosary, which may also be associated with the Harrison sulcus as well. And another very important point in the assessment of the shape of the chest is to look out for any sort of drooping of the shoulder, which is again very important. Now the examiner will ask you, yes, if you comment, okay, sir, this patient has a drooping. Now the examiner will ask you this question. Okay, if the patient is having a drooping, what does that indicate? Now always remember, very, very important point, drooping indicates volume loss. Say along with me, drooping indicates volume loss of the same side. For example, if the patient is having a significant fibrosis, so there is a fibrosis of the lung, okay? So there is a volume loss, or there is a collapse of the lung. So both these are characterized by volume losses, and that is when you get drooping. It is usually seen in a chronic disease process, that in case of an acute disease process. Okay, that is another point that you should be looking at. And when you are, when you are asked by the examiner to observe for drooping, make sure that the patient is standing and the examiner is standing from behind, and he should be inspecting for any sort of drooping. And when do you say that there is drooping? Now, out of these 3 points, when you have 2 at least, that is a lower level of shoulder on one side, a shorter spinoscapular distance on that side, with a prominence of the medial border of scapula. Out of these 3 points, if any of 2 are present, that is when you can say there is drooping, and yes, there is a volume loss. Okay, that is what you have got to understand. Next, coming to the position of the trachea. Again, position of trachea can be assessed by inspection as well as palpation. So inspection, you look, visually, does it appear to be central? So normally we know that the position of trachea is relatively central. Now if the patient is having a tracheal shift or not, you will have to comment. Now this is very, very important. What is the clinical relevance of tracheal shift? Because if at all you are commenting about tracheal shift positivity in your examination finding, mind you, you are committing that there is some sort of an upper mediastinal shift. That is what, there is a shift of the upper part of mediastinum. So when you have got a tracheal shift, there are certain pathologies that will cause a tracheal shift to the opposite side. and certain pathologies which will cause a tracheal shift to the same side. Now, when you have a tracheal shift to the opposite side, you can think of these as pushing lesions. Pushing lesions. These are pleural effusions, pneumothorax, and mass lesion. Mass lesion means maybe a malignancy. These are pushing lesions. But let me tell you something. It doesn't mean that. This is again something very important. Often when students learn for Final MBBS practical, okay, they might learn, okay, pleural effusion has tracheal shift. So it is one of the causes of tracheal shift. So when they get a case of pleural effusion for the exam, even though in examination they don't feel like there is a tracheal shift, still they remember, I've read somewhere that in pleural effusion there is tracheal shift, and you write that there is tracheal shift. My dear children, in your exam, please use your logic as well. Let me ask you one thing. You tell me about pleural effusion producing a tracheal shift. You tell me, is it going to be a mild effusion or a severe effusion that produces a tracheal shift? Do you think a small effusion, for example, in your exam, suppose there is a pneumonia with a symptomatic effusion. Okay, pneumonia with a symptomatic effusion. You tell me, symptomatic effusions are usually mild to moderate or severe? Usually mild to moderate. So do you think a mild to moderate effusion can produce a tracheal shift? No, as I told you, it is an upper mediastinal shift. That is what you are committing when you say that there is a tracheal shift. So it has to be a large effusion. And what about pneumothorax? Will a small pneumothorax produce a tracheal shift? No, it has to be a large pneumothorax. And mass lesion. Do you think any sort of mass lesion will produce a tracheal shift to the opposite side? Suppose there is some sort of a malignancy. What do you think? A malignancy involving upper lobe or lower lobe, which is likely to produce a tracheal shift? It is upper lobe. So it is a large effusion, it is a large pneumothorax, and it is an upper lobe mass lesion that is likely to produce a tracheal shift to the opposite side. That is what you should be understanding. Now, when it comes to tracheal shift to the same side of pathology, is it going to be a pushing lesion or pulling lesion? It has to be a pulling lesion. So this is fibrosis or collapse, volume loss. That is when the trachea will shift to the same side. Okay, and again remember, mild degree of fibrosis may not have a tracheal shift. The trachea will still be a central. That is why trust your instincts and trust your examination abilities. That is what I want to tell all my dear students. And when you face the practical exam, let me tell you, there is no need to be scared. I am sure that many of you facing the practical exam are scared. Sir, I think I'll fail. This is probably the first time I'm hearing about all this. I don't know how to examine. I think I'm visualizing failure. My dear children, please don't think like that. Do you think that all the doctors that you see around, the successful ones, are all who have performed wonderfully well during MBBS? It's not always like that. See, even if you feel that you are lacking knowledge, why don't you try? At least now, maybe you are at the blink of the exam, but still you try now, you listen to this lecture, note down the points, and what if by your luck you get a similar simple question or simple case for your exam and you can perform well. So never underestimate yourself. You're all capable children. The only thing is that you have to learn in a systematic manner, revise it 1 or 2 times, and then go to the exam hall. That's what I want to tell you. So don't go for too much theoretical knowledge and never try to be a master in medicine. I always tell this, that nobody can be a master in medicine. We all should be humble. So do not think that when you take a subject like medicine, okay, I'm going to be the master of medicine. Nobody can be. If anybody thinks like that, you can only be living in a fool's world. So in medicine, I'll tell you something honestly. When I go to the OP, something I pray for is that God help me with the knowledge that I have, that I like to make more correct diagnosis than wrong diagnosis, what I actually pray for. And we all should be humble. This is a big subject, and we are all learning. You are learning, I am learning, all of us are learning, right? Now, what about no tracheal shift? No tracheal shift can be there in many conditions. Like, it's neither a pushing lesion nor a pulling lesion. So this is actually in case of conditions like consolidation, bronchiectasis, interstitial lung disease, COPD, bronchial asthma. These are the conditions that you should be aware about. Okay, right. So one student is asking, is trachea having a mild physiological right-sided shift in some patients? Yes, you're right. Physiologically there can be a mild shift, but generally we say that normally position is central. So I can see Dr. MBBS asking. Yes, Santosh is actually a very dear friend of mine. I definitely know Santosh is a dear friend of mine as well. Thank you for asking that. Okay, now coming to trail sign. So what is this trail sign? This is again something that is commonly asked, which is basically meaning the prominence of the sternocleidomastoid on the side of tracheal shift. So suppose if there is a tracheal shift to the right side, what happens is that the the pretracheal fascia over the sternocleidomastoid, so that becomes a little bit loose. And because the fascia becomes loose, the sternomastoid will attempt to contract so as to keep the fascia taut, which will result in the prominence of the sternomastoid. This is what is referred to as the trail sign. That is something that you should be knowing at. Okay, right. Now coming to the next finding, because we have just seen the shape of chest, position of trachea. Next we go on to the position of the apex beat. Okay, position of apex beat. So position of apex beat, here also you should be thinking about shift of apex beat. Apex beat is shifted in case of pleuropulmonary diseases, especially involving the lower lobes. That is important. So which means if you are telling in your examination that there is an apex beat shift, listen to me carefully. If you commit in the examination that there is an apex beat shift, means you are committing that there is a lower mediastinal shift. So what did I say? Tracheal shift, upper mediastinal shift. Apex beat shift means lower mediastinal shift. This is very, very important. Okay. See, what I want you to understand is when you write the case sheet in your exam, never contradict your own findings. Okay, never contradict your own findings. Suppose you are saying that there is a massive effusion on one side, okay, and then you are saying that the apex beat is normal, then you are contradicting your own finding. So be a bit watchful, and when you write your findings, be logical as well. Now coming to the shift of apex beat, again shift to the same side, pushing or pulling lesion. Pulling lesion, what are they? Fibrosis, collapse. To the opposite side of pathology, pushing lesions, what are they? Pleural effusion, pneumothorax. Now in certain cases the apex beat may not be felt, as in case of maybe a left-sided pathology, that is where you get the apex beat. So maybe a left-sided large effusion, it doesn't mean that more like mild effusions you may still be able to get a apex beat, but when you get a large left-sided pleural effusion, a large left-sided pneumothorax, or maybe even emphysema, the apex beat may not be felt. I'm not saying that all cases of emphysema, apex beat may not be felt, but when the patient is having a prominent emphysema, predominant COPD, then the apex beat may not be felt. Next, coming to the inspection of respiratory movements. Mind you, respiratory movements can be assessed both by inspection as well as palpation. Okay, so coming to the assessment of the respiratory movements, it has to be examined in the upper and lower part of the chest, both anteriorly and posteriorly, and you will have to make a comment whether the respiratory movements are equal or the respiratory movements are diminished. Now the examiner will ask you what are the causes of reduced movements. Remember, you have reduced movements on one side, reduced movements on both sides. So one side, pleural effusion. Again, I am telling you, I am just giving you a list, but you be logical. Do you think a very mild effusion in case of a symptomatic effusion may produce a significant reduction of movement? May not be, may not. So these have to be prominent, then only you will have the respiratory movements being affected on that side. So pleural effusion, pneumothorax, fibrosis, collapse, consolidation, mass lesion, all these pathologies will cause reduced movements on one side, whereas certain conditions can cause reduced movements on both sides, like chronic obstructive pulmonary disease, interstitial lung diseases, as well as ankylosing spondylitis. Okay, right. Okay, right. Okay. So that is what you have to know about respiratory movements. Next, coming to the respiratory rate. So normal respiratory rate, again, between different textbooks, they do quote slightly differing ranges, but the standard respiratory textbooks, they quote between 12 to 18 per minute. Some books you can see 12 to 16, 14 to 18, but on an average 12 to 18. And again, you will be asked in your Viva, what are the causes of tachypnea, what are the causes of bradypnea. Tachypnea can be due to anxiety, fever, exercise, pneumonia, pulmonary edema, acute respiratory distress syndrome, acidosis. Bradypnea can be due to conditions like raised intracranial tension as a part of the Cushing's reflex, then narcotic poisoning, mixed edema, coma. These are some of the causes of bradypnea that you should be aware about. Then about the rhythm of respiration. Look, the normal rhythm is a regular rhythm. And what are the abnormalities in the rhythm of respiration? You can have the waxing and waning type of respiration, which is the Cheyne-Stokes breathing, which may be associated with raised intracranial tension, narcotic poisoning, and left ventricular failure. And another similar type of respiration, that is Biot's, wherein also you will get periods of hyperpnea and apnea. But unlike chain strokes, you will not be having the typical waxing and waning type of respiration. Beyonce is seen in case of meningitis, apneustic breathing in case of pontine lesions, ataxic breathing in case of medullary lesions, and Kussmaul breathing, the famous one, in case of metabolic acidosis, commonly due to a diabetic ketoacidosis. Okay, right. Now coming to the type of respiration. The normal type of respiration is abdominothoracic in males and thoracoabdominal in females. So abdominothoracic means, both the diaphragm as well as the rib cage, both are contributing, whereas in females mostly it is the rib cage that is contributing, which is the thoracoabdominal type. Now in pathologies you can have alteration of this type. A thoracic type of breathing can be seen in case of any sort of diaphragmatic paralysis, where you will have to depend entirely on the rib cage. So thoracic in diaphragmatic paralysis as well as in peritonitis, whereas abdominal type can be seen in pleuritis as well as maybe in some cases of chronic obstructive pulmonary disease. Intercostal retraction that you should be looking out, especially when you have got a long case of a chronic obstructive pulmonary disease. And this intercostal retraction occurs when the accessory muscles are working. That is what, when you comment that the patient is having intercostal retraction, you are commenting that yes, the accessory muscles are working. And some basic points that you should be knowing for your Viva is that inspiration is normally an active process that is mediated by the diaphragm and the intercostals, and the expiration is a passive process which occurs due to the elastic recoil of the lungs. The examiner will ask you, tell me what are the accessory muscles of inspiration and expiration. Inspiration, it is scalenus, pectorals and trapezius, whereas expiration, it is the abdominal muscles and the latissimus dorsi. I hope it is clear. Now coming to the palpation, again you have to have the checklist in mind. That is what, when you go to a practical exam, you have to have the checklist in mind. So palpation, position of trachea, apex beat, respiratory movements, chest expansion, the anteroposterior and transverse diameters, vocal fremitus, and any sort of intercostal narrowing are the findings, they are the checklist findings that you should be looking out in the palpation part. So again, when it comes to the position of trachea, as I said, you can assess it by inspection, you can also assess it by palpation. And how do you palpate for the trachea? Again, the examiner is going to ask you to demonstrate it. Remember, the patient should be in the sitting position with the neck slightly flexed and the chin in the midline, the index finger as well as the ring finger placed on two reference points, which are the sternoclavicular joints, and then with the middle finger you will palpate the tracheal rings with the middle finger from above downwards. That is how you will be palpating, to look for any sort of tracheal deviation. And then other points, apex beat, I have just told you points regarding apex beat. Regarding respiratory movements, again, I've already told you it can be assessed by inspection as well as palpation. How to assess the respiratory movements? Again, I'm not able to show as this is an online class and I have got limitations in an online class. But again, I want you to be thorough on the examination of the respiratory movements as well. Please do feel free to ask for any doubts that you have got in my academic groups as well. Now, coming to the chest expansion, that is something you have to look for. So chest expansion is measured. Okay, it is measured using the measuring tape. And for the males, again, they will ask you, you show how to look for chest expansion. So males, you will look at the level of the nipples, whereas females, since you have got the breast, you will be looking below the level of the nipples. And you can look at the total chest expansion as well as the differential expansion, that is the expansion of the hemithorax, because in certain pathologies, it is the hemithorax that can be affected in unilateral pathologies. So when you look at the total chest expansion for a normal individual, it has to be above 5 centimeters, and abnormality means less than 3 centimeter in males, less than 2.5 centimeter in females. That is what is abnormal. Then you will have to assess the anteroposterior and transverse diameter. This is done, using the certain books or, cardboard you can use to identify. This is done at the level of the fourth intercostal space, is how you will palpate for examine for the AP and transverse diameter. Next point is about the vocal fremitus, important. So vocal fremitus, examiner will ask you, show me how to demonstrate vocal fremitus. Remember, vocal fremitus is sometimes also referred to as a tactile vocal fremitus. Examiner will look, how are you demonstrating for vocal fremitus? It is using the ulnar border of the hand that is used horizontally in the intercostal space. You ask the patient to repeat either 1-1 or 99-99. So basically what is being checked for is that when you use this sound from the vocal cord, there is transmission of the sound along the tracheobronchial tree. And there are certain conditions in which the vocal fremitus will be increased, as in case of consolidation or maybe even the upper level of a pleural effusion. And a decreased vocal fremitus can be seen in conditions like pleural effusion, pneumothorax, fibrosis, as well as collapse, where the conduction will be affected. Obviously, when you have got some fluid or maybe air or maybe fibrous tissue, the conductance will be reduced significantly. Okay, right. Next, coming to the rib crowding. Next, coming to the rib crowding. So how do you assess for rib crowding? This is again something important. If definitely in your exam you have got a long standing fibrosis or collapse, you will be asked to demonstrate whether the patient is having some sort of a rib crowding. Remember, patient in the sitting or standing position, the examiner stands behind the patient, and along the lower intercostal spaces, he'll slide his fingers along the lower intercostal spaces to look for any sort of rib crowding. And what are the conditions in which you may get rib crowding? It can be either in a fibrosis or maybe in a collapse. These are the conditions where there is a volume loss, that is where you get the rib crowding. Now, after inspection and palpation, next is about the percussion. What are the important points that you should be knowing? See, you've got the left hand, the middle finger of the examiner's left hand is referred to as the pleximeter finger. The examiner's right hand is referred to as the flexor finger. So the preferred position, this is again important. The examiner will ask you, if you want to percuss a patient, what is the preferred position? It is sitting up. But does that mean that you can only percuss in the sitting up position? No. Especially if the patient is sick, you will have to percuss with the patient lying down, no problem. But the ideal preferred position is the sitting up position, and you will have to percuss the anterior chest, axilla and posterior chest. And when you percuss, you make sure that the percussion movement is actually coming from a wrist. There should be a free flowing movement from the wrist and not the elbow. That is what you will have to practice percussion, and the examiner will be looking, from where is that movement coming. And when you are dealing with pathologies, this is another point that I want to tell you, always try to percuss from the resonant area to the non-resonant area. Now that is, better for comparison. Resonant means, how do you know it is resonant? You probably know in which side, by the clinical judgment of the patient's history, what are you looking at? Maybe, there is it looks like from history that there is some sort of an effusion. You then percuss on the other side, resonant area to the non-resonant area. But always when you percuss over identical areas for comparison, okay? So that you will be able to come to logical conclusions as well. Now again, you must know that the normal resonance is actually called as normal, or you simply say it is resonant. Now, impaired occurs in fibrosis and collapse. Dull occurs in consolidation and mass lesion. Now, what is the basic difference between this impaired and dull? Impaired is something that is between the normal and dull. That is what you call as impaired, between the resonance quality of a normal and dull. So impaired is in fibrosis and collapse, and dull in case of consolidation and mass lesion. Stony dullness is associated with an effusion. Hyperresonant note with a pneumothorax, and tympanic resonance is associated. Maybe you percuss over the region of stomach, you get a tympanic resonance. Now when you percuss, you are using the flexor finger as well as the pleximeter finger, but you can go for direct percussion where over the bone, especially on the middle third of clavicle. When you percuss after stretching the skin, and you can directly percuss on the middle part of the clavicle, because on either side you may not be able to get a resonance, but on the middle part you will be able to get a resonance because you don't have much muscle attachment. So in the middle part, when you percuss, you will get a resonant note. So direct percussion over the bone, and all other places it is indirect percussion using your flexor and pleximeter finger. Okay, right. Now a few other points the examiner is often interested in will be about what is a chronic isthmus. They will ask you what is a chronic isthmus. You will have to say the boundaries, and next is the clinical significance. So boundaries: medially the root of neck, in front the clavicle, laterally the acromoclavicular joint, that they are the boundaries. Then examiner will ask you what is the clinical significance, because in the chronic isthmus you have got the apex of the lung. So when you have got a mass lesion in the apex of the lung like a Pancoast tumor, the normal resonance will be lost. That is the clinical significance. Next is regarding the tidal percussion. This is again important. So I am not going into the too much details regarding that. It is again an examination finding. It's basically done to differentiate between a supradiaphragmatic pathology and an infradiaphragmatic. Infradiaphragmatic, for example, I am meaning it is a subphrenic abscess. Subphrenic abscess. So if you want to differentiate between supra-diaphragmatic and infra-diaphragmatic pathology, you will have to go for tidal percussion. And again, examiner will ask you to demonstrate the tidal percussion. So, but since this is an online session and I don't have a normal subject or a patient with me, I'm not able to demonstrate that. Okay, right. And another point the examiner will ask you is regarding the trop space, the boundaries, and the clinical significance. So boundaries of the trop space: above sixth rib, below the left costal margin, and laterally you have got the left mid-axillary line. These are the boundaries. So normally, you have a resonant note over that region, but when you have got a large left-sided pleural effusion, this trop space may be dull. So one of the causes, there are other spaces of trop space dullness as well. One of the causes of a trop space dullness is a left-sided pleural effusion. Okay. Next is examiner will ask you about shifting dullness, and he might also ask you to demonstrate shifting dullness. So the patient will be in the sitting position. You have to percuss the anterior chest from above downwards, and you identify the area of dullness, and you keep your pleximeter finger there, and then ask the patient to lie on the healthy lateral side, wait for 30 seconds, and then percuss again. And what is the clinical significance of this? It may be seen in hydropneumothorax. So sometimes what happens is, even if your case is not a hydropneumothorax, the examiner, just to know how whether you will be able to demonstrate shifting dullness, will ask you to demonstrate shifting dullness. So all of you who are listening to my lectures, please, in a normal subject, before you go to the exam, you just practice all this. Otherwise, you'll mess it up in the exam. So stay calm and relaxed. You just look at the basic points and go to the exam hall. You will do reasonably well. Okay, right. Now coming to the auscultation part of it. Now when you auscultate, you will have to auscultate the anterior chest, the lateral chest, as well as the posterior chest. So in the anterior chest, you will have to auscultate in the supraclavicular area, infraclavicular area, and the mammary area. So from the third rib onwards, it is the mammary area. And then the lateral chest for the axillary and infraaxillary area, the posterior chest, the suprascapular, interscapular, and the infrascapular area. So these are the areas to be auscultated. Now, what all will you be looking at? You will be looking at number 1, the breath sounds. Number 2, any sort of adventitious sounds. Number 3, the vocal resonance. And number 4, the miscellaneous sounds. These are the points that you should be looking at. Now coming to the breath sounds. Now when you look at breath sounds, there are 2 points that you have to look, and the 2 points that you should be writing in your case sheet. Number 1 is regarding the intensity of breath sounds. Number 2 is regarding the type of breath sounds. When I say intensity of breath sounds, you please understand, normally it is breath sounds is normal and equal bilaterally. But what is the abnormality? It can either be diminished or it may be absent. Correct or not? Yes. Now coming to the type of breath sounds. Okay. Before we go to the type of breath sounds, let me just give you points about the causes of diminished breath sounds. So diminished breath sounds can be a bilaterally diminished breath sounds, as in case of conditions like chronic obstructive pulmonary disease, as well as interstitial lung disease, as well as unilaterally diminished breath sounds, as in case of pleural effusion, pneumothorax, collapse, conditions like fibrosis, consolidation, mass lesion. But remember, though I said diminished, maybe in a large effusion, you may even have absent breath sounds. So pleural effusion can even produce absent breath sounds as well. That is also possible. Okay. Even in case of, pneumothorax as well, you can have absent breath sounds. Okay. So diminished in case of milder, and severe cases, definitely absent breath sounds. Now coming to the next point, that is regarding the type of breath sounds or the character of breath sounds. That is what you should be looking at. So the character of breath sounds. Now remember, in a healthy lung, the character will be normal. And what is a normal character? A normal character will be vesicular, which is low pitched and soft. Why is a normal breath sound low pitched and soft? Because the alveoli will actually filter out the sound, and that is why it is in a normal individual it is low pitched and soft, and you won't hear the same flow of air that you hear over the trachea. You will not hear it over the alveoli, because the alveoli will selectively filter the sound. That is why it will become low pitched and soft. Now coming to diseased lung. Diseased lung, you get bronchial breathing. Now bronchial breathing is of 3 types. One is tubular, cavernous, and amphoric. So there are 3 types. So tubular breathing is heard over a consolidation. It is similar to the sound, when you blow over a small, say a tubular pipe, is a tubular breathing. Cavernous means, if you are blowing over a small bottle, that is a cavernous breathing. Amphoric means if it is a large bottle and you are blowing into that, that is amphoric type of breathing. So cavernous is heard over a cavity. And when you have a large communicating cavity, that is where you get a amphoric breathing. So basically, Amphoric is slightly unique in that it has got a slight metallic quality. That is the important point that you should be knowing about amphoric breathing. Okay. Now, when you compare vesicular and bronchial breathing, sometimes the examiner will ask to draw the vesicular type of breathing. So the vesicular type of breathing, when you draw it, you can see there is an inspiratory part and expiratory part. So assume that this red one is the inspiratory part and the green one is the expiratory part. So you can see that expiration is shorter than inspiration and there is no pause between the inspiration and the expiration. You can see there is no pause between inspiration and expiration, there is no pause. But when it comes to bronchial breathing, what happens is that when you look at this, you will see that there is a definite gap between inspiration and expiration. Okay, so this is inspiration, this is expiration. So you can definitely see there is a gap, and as well as the expiration will be almost equal to or sometimes even longer than inspiration. Okay, it is almost equal to or even maybe longer than inspiration. So that is what is a bronchial breathing. And sometimes patients can have a combination that is called a bronchovesicular breathing, where you get something like this, where it's the expiration is almost like that of inspiration, but there is no pause. That is what is a bronchovesicular type of breathing. Okay. Now coming to the adventitious sounds. So I told you that you may also get adventitious sounds. So what are the adventitious sounds that you should be knowing about? You should know about this rhonchi, which is a musical sound, and rhonchi suggests some sort of airflow limitation. And this can happen in case of a bronchial asthma and COPD. So rhonchi is also sometimes referred to as wheeze. But if you ask me, sir, rhonchi and wheeze are exactly the same or not? Well, there is actually a slight difference. It is basically, it is a low pitched rhonchi is what you call a wheeze. But again, the problem is it is difficult to differentiate clinically. So clinically, generally you say that rhonchi and wheeze more or less the same. So at your level, you just think that rhonchi and wheeze both are the same. Now coming to crepitations. Now crepitations, well, there are different types of crepitations. One is a fine crepitation. So where do you get fine crepitations? So fine crepitations means, it has got a popping quality for that crepitations, popping quality. It is seen in case of an early stage of consolidation, pulmonary edema and fibrosis. That is when, a narrowed airway is getting opened. That is when you get this fine crepitations. And in case of fibrosis due to ILD, in case of fibrosis due to interstitial lung disease, you have got a special type of crepitation. It is known as Velcro crepitations. Just, when you open the BP apparatus cuff, the sound that you're hearing. So that is the Velcro crepitations. Then about coarse crepitations, because the examiner will ask you, tell me some causes of fine crepitations, tell me some causes of coarse crepitations. So coarse crepitations means, when air is coming to that airway which contains secretions, there will be some sort of a bubbling sound. So, in case of resolving pneumonia, there will be some sort of, exudates there. In bronchiectasis, you have got secretions, lung abscess. So whenever you have got these secretions and air is flowing through that, it will create some sort of a bubbling sound. That is what is a coarse crepitations, and you must know about the coarse crepitation etiologies. Another favorite question for Viva is about the typical type of crepitations that you get in bronchiectasis. You get early inspiratory coarse crepitations in bronchiectasis, and in pulmonary edema you get late inspiratory fine crepitations. Okay, right. Now coming to vocal resonance, almost similar to that of vocal fremitus, only thing is that this is an auscultatory finding and you ask the patient to say 111 or 99, 99, 99. So conditions where you have got increased vocal resonance is in consolidation as well as the upper level of effusion, whereas you get decreased vocal resonance in case of pleural effusion as well as pneumothorax. Okay, so my dear children, don't worry regarding this. I know that some of you, sir, too much of information. My dear children, who is an expert at first? Nobody is an expert at first. You will have to keep repeating it again and again and again. Even if you are near the exam, just go through this class first and then go through this PDF again. I've already shared the PDF with you. I think that means things should be a lot easier for you. Okay, so that is what you have to understand. And yes, you will have certain miscellaneous sounds other than the adventitious sounds like bronchophony, agophony, whispering petrolochi, pleural rub, coin sound, post-tussive suction. So what are these miscellaneous sounds, mechanism, These are important, but again, I'm not going too much into the detail because this is relatively going to be exam focused class. But if you are looking for some extra marks, you should be aware of what are these miscellaneous sounds. We can probably discuss in our academic WhatsApp groups as well. If you have got any doubt regarding this, I'll definitely be helping out in my academic groups as well. So this is what I want to tell you about the history and examination. But one last very important slide is this. I know that somebody is asking what is crackles. Crackles and crepitations mean the same. So Dr. Vishnu, crackles and crepitations essentially mean the same. Now this is one flow chart, one table that you should be aware about. I'm sure that this looks quite an exophthalmogenic table. As you look at it, too much of information with too much of diseases. Sir, are you trying to make it simple or trying to make it complicated? Well, what I've just tried to do is put down all the common long cases that you will get in your exam, or maybe even the short cases, and just given you a checklist of the important findings in each of this. Let us try to see each of them. Okay, so if you look at consolidation, it's always easy to compare and learn. When you look at tracheal shift, you can see that consolidation cavity, okay, may not have shift. Emphysema may not have shift. So what I'm saying is, tracheal shift may not be there if you have got these conditions like a consolidation, cavity, emphysema, because these are not significant pushing lesion or pulling lesion. But when you have got a pushing lesion like a pleural effusion, like a mass lesion, like a pneumothorax, you get a tracheal shift to the opposite side. But does it occur in all conditions? No. In case of a pushing lesion like fibrosis, collapse, you will have to the same side, and bronchiectasis also nil. Okay, right. Now coming to the mediastinal shift. Mediastinal shift, when you look at it, consolidation, cavity, emphysema, bronchiectasis, not much of a mediastinal shift. Again, shift to the opposite side. Again, the same logic as of pushing lesion and pulling lesion. I've just listed it down. I think you are quite familiar with these terms, pushing and pull, right now. Now coming to respiratory movements and chest expansion. In case of consolidation, you may have diminished movement of the affected area. So just because somebody has a consolidation involving the lower lobe, the respiratory movement may be decreased in that part only and not the other parts. Okay, pleural effusion will be diminished, fibrosis diminished, collapse diminished, cavity reduced again, mass lesion diminished, normal or diminished. Okay, cavity reduced means diminished, that's it. Okay, then coming to percussion. So I've already told you, I'm not going to repeat it. I've already told you what are the percussion abnormalities that you're going to get. Vocal resonance, increase in consolidation, reduced effusion, fibrosis decreased, collapse reduced, cavity increases if there is a communication with the bronchus. That is what you have got to understand. So cavity, it is not always the same. It is variable, but it increases if there is a communication with the bronchus. Okay. Mass lesion decrease, normal or decreased in emphysema. I told you earlier. So a bronchiectasis, it is variable. Okay, it is variable. See, this is what I want. This is just a a superficial checklist. Based on the severity, you may have differences. It is not that these are hard and fast. It depends on the disease severity as well. And coming to breath sounds, in case of consolidation, you may get a diminished or absent. But again, you may also get a tubular type of bronchial breathing. Pleural effusion, it may be absent. Fibrosis decreased. Collapse absent. Cavity, you may have a cavernous breathing. Mass lesion decreased. Pneumothorax absent. Emphysema diminished. Bronchiectasis often quite normal. Adventitious sounds, consolidation, press, a pleural effusion, you are less likely to have any sort of adventitious sounds. Fibrosis, you may or may not get, but you are likely to get crepitations. Okay, and collapse, you may not get any sort of crepitations. Now, there is one important question which I want to ask you. Let me see who is well versed with this. Can you tell me what is that single most important examination finding that is going to help you differentiate between fibrosis and collapse? Can you tell me? There are so many similarities between fibrosis and collapse, but what is the single most important factor that actually helps you? Answer is crepitations. Crepitations may be seen in fibrosis, but it's not seen in case of collapse. So then mass lesions, nil, emphysema, rhonchi, coarse leathery crepitation in case of bronchiectasis. Here you're not going to have any significant adventitious sounds again in case of cavity as well as the pneumothorax as well. Miscellaneous sounds in case of consolidation. Again, this is something that you have to read for some extra marks. Bronchophony, egophony, and whispering pectoraloquy. In pleural effusion, remember at the upper level of the effusion, you may get egophony here. Okay, fibrosis. Nil, collapse nil. Cavity, you may get a post-tussive suction, again something that is important. Mass lesion nil. Pneumothorax, again coin sound. Sometimes the examiner might ask you to demonstrate the coin sound. Emphysema, bronchiectasis, not much of significant findings as well. So that's it. We come to a close of this this session where I've tried to give you an overview of the history taking and examination in case of respiratory system. Again, I tell you that no clinical medicine class is complete. What I have tried to do is to help the final MBBS students to have a reasonable judgment ability on the history as well as examination with the possible important questions that can be asked for your Viva. Any more doubts, you can stay connected with me. This is my Instagram academic page. You can stay tuned to the academic page as well. You can also just follow this YouTube channel for more such academic videos as well. And yes, this is my medicine WhatsApp channel where I put MCQs and other facts related to medicine. I hope I have been able to give you some good insights regarding the respiratory system. With the short time that I have got, I think under 1.5 hours, whatever is best possible, I think I have tried to give you. Now what you have got to do is just go through these notes once again, take a normal subject at least, do a thorough round of examination, and I hope you will be able to do a reasonably good job. That is what I feel. So thank you so much everyone. So I hope all of you have been benefited, and stay tuned for more such sessions as well to this channel. Okay, thank you so much everyone for joining. Yes, thank you Vishnu. Thank you Vishnu for that. Okay, thank you Shasa. Simpson, Vishnu, yeah, MBBS. Okay, right. Thank you so much, everyone, for joining, and wish you good luck. Thank you so much.